The best interest checklist is all about trying to work out what would the person have wanted if they had capacity to make the decision for themselves. And the first thing to do is try and encourage as much participation as possible. It's very rare for someone to completely lack capacity for any decision at all or be able to communicate at all. Quite often you can find something that they've got to say that helps you work out what it is they might like. Even looking at their actions rather than their verbal communication, you can try and work out what someone likes and doesn't like. People have to avoid discrimination when making a decision in someone's best interests. So you can't go making a decision based on someone's age or appearance, for example. Another thing to do is consider whether the person might regain capacity at some point, and can you delay making the decision until that happens? Sometimes people have better times in the morning, for example. So if you find yourself having to make a decision in the afternoon, but it could wait till the morning, wait till the morning and talk to the person then and find out what they want then. Under the Mental Capacity Act, it can never be in someone's best interests to die. So you're not allowed to make a decision that would lead to someone's death. When someone has capacity to make decisions for themselves, they're allowed to make decisions about every aspect of their life. If that decision ultimately leads to somebody dying, that's their choice, and that choice should be respected, and they should be allowed to make that. When someone loses capacity to make decisions for themselves, that power isn't granted to agents of the state, if you like. So doctors, social workers, nurses can't make that decision that someone should die in their best interests. It's important to consult with people who love or care for the person about whom the decision is being made, to find out what they think, to gauge their opinion about what's in that person's best interests. So if you think about someone who has a phobia of going to visit the dentist and they have a very, very severe toothache, you could argue that their phobia of going to the dentist renders them incapable to make a decision about whether or not they should go and have their toothache sorted out. So they lack capacity to make that decision. Would it be best to send in a heavy squad of police officers to control and restrain that person while someone gives them a tranquilizing injection, and then you cart them off to the dentist's while they're unconscious to take their tooth out? You couldn't argue that that's in that person's best interests, because there are lots of things you could do that would be less restrictive than that. Allow them to visit the dentist on a day when they're not going to have any treatment. Let them meet the dentist. Let them see someone else having the same procedure, for example, to try and lessen their anxiety. Somerset Partnership Trust has developed its own set of forms for people to fill in to show that they've assessed somebody's capacity, and then if the person lacks capacity, how they've worked out what's in someone's best interests. Those are the forms that we expect staff to be completing when they're carrying out capacity assessments. The kind of general rule of thumb is that if there's a big important decision to be made, that has to be recorded really clearly and carefully. When it comes to day-to-day decisions, it's usually enough to do a care plan that will say what's been decided in someone's best interests, say for the week. The most common example of good practice, I think, is where professionals decide to have something that we call a best interests meeting. So when there's a decision that's quite finely balanced and might have some quite a significant impact on the individual, you get everyone together in the room who has a role to play in making that decision, and discuss it and listen to other people's opinions and take everything into account and use that as a basis for making the decision that's going to be made. People always think they're doing what they should be doing. It's just a case of sometimes they don't realise the framework they should be doing it within. So, for example, people who don't carry out capacity assessments of people who are placidly complying to things, That's probably the thing I'd like to see improve the most around the trust. A calm acceptance of a treatment doesn't necessarily equate to capacitated consent. People have to have capacity to consent. The Capacity Act has this presumption of capacity principle where you have to assume that the person you're seeing has capacity to make decisions. And so there is a tendency amongst staff sometimes to presume capacity every time somebody isn't resisting. Because that's quite easy, isn't it? If someone turns up, say for an injection, and just sits there while they have it, it's quite easy to think, well, they must be consenting because they're not objecting. Whereas in fact, they might just be placidly complying without having any idea what the injection is or what it's for or what its potential side effects are. So staff really need to be thinking about that and not just thinking about a capacity assessment being something you do to someone who's resisting. It's something you should do every time you're working out whether or not someone is consenting to the treatment you want to give them.
Mr. Thompson, time for your injection.
What if I don't want an injection?
People can only consent to treatment when they have the capacity to do so. So unless that person knows what the medication is that they're taking, and they know about the potential side effects, and they know what the condition is that the medication is meant to be treating, unless they know all those things, they're not actually consenting to take it. They're just passively complying, not resisting.
"7:30. Time to get up, Mrs. Lawrence."
But I don't get up at 7:30.
It's very tempting when people work in some kind of institutionalised setting, like a care home or a hospital, for their needs to start taking precedence over the needs of the people they're caring for. So if you've got 20 people that you need to get to breakfast for 8:30 in the morning, you might think, well, we'll have to start getting people up at 6 o'clock then in order to make sure they're all ready in time for their breakfast. Individuals have individual needs, and some people might not want to get up at 6 o'clock just to have a warm breakfast, or some people might not even want a warm breakfast. You have to be much more individual-centred and make decisions on an individual's best interests, not on the best interests of the institution or the staff.
Right, that's bay 1 consented. I'm going to do bay 2 now.
I've come across this phrase a few times now where people go and consent a patient for a particular form of treatment. And that's really turning the Capacity Act on its head, because giving consent is something a person grants voluntarily. It's not something they do to someone. You can't consent someone to do something. So staff, instead of thinking that they are consenting someone to a treatment, they have to be thinking, I'm actually going to see whether this person understands the treatment that's being offered, and then whether they are giving their consent to it. One of the myths about the Mental Capacity Act is that you're not allowed to place restrictions on people, even when that might be in someone's best interests. Now, that is a myth, because the Mental Capacity Act does allow that to happen. One of the reasons this myth is so potentially dangerous, if you like, is sometimes people can decide not to intervene when they should be intervening to prevent harm coming to someone. One of the examples I came across once was someone with a learning disability who would frequently bang their head against a concrete wall. The staff in the place where he was living thought they had no right to intervene to stop that happening, because to do so would be placing restrictions on the person, and you mustn't do that. But that's just incorrect. If that person lacked the capacity to realise what potential damage he was doing to his head when he was banging his head, then the staff should be intervening in his best interests in order to prevent that harm from happening. And to stand back and let him do it could actually be neglect, rather than respecting his wishes, which perhaps is what they thought they were doing.